Hello everyone, welcome to today's short video presentation on age factor in orthodontics. The contents of today's presentation will be introduction to growth and development, who are adult patients, diagnosis and age, treatment and age, how the treatment differs and diagnosis differs with age, tooth movement and age, and what are the basic differences between young versus adult patients in orthodontics. Todd defined growth as growth is an increase in size. It is the simplest definition of growth. Similarly, Krogman defined growth as increase in size, change in proportion, and progressive complexity. Profit defined growth as an increase in size or number. Development, on the other hand, it is progress towards maturity according to Todd, and according to Moyers, all the naturally occurring unidirectional changes from a single cell to multinational unit terminating in death, that is development. Factors affecting growth, there are different factors like genetic factors affecting the growth. Heredity plays a very important role, and growth hormones and growth factors like insulin like growth factor 1 and 2, IGF-1 and 2, platelet derived growth factor, PDGF, epidermal growth factor, vascular endothelial growth factor, all these play a role in growth. Similarly, nutrition, well-nourished child are well grown, whereas the malnutrition may affect the size of parts of the body, proportions, quality, and onset of growth events also. Similarly, secular trends in the last 100 years, 200 years, in the past generations, people used to be of a small size, but these days a general increase in size has been observed, and because of illness also, another factor affecting growth is illness. If in the childhood some chronic prolonged illness is present, growth can be retarded. Season and circadian rhythm also affects the growth. It is noticed that in autumns the growth is more, in nighttime growth is more compared to the daytime. And psychological stress also affect growth. If the children are experiencing stressful conditions, and growth hormone secretion is inhibited, and that will result in markedly retarded growth. Different parts and organs of the body grow at different times and to different extents. This is termed as differential growth, which can be seen in human as basically two things: cephalocaudal gradient of growth and Scammonn's growth curve. It will reflect the differential growth in humans. Let's see what is cephalocaudal gradient of growth. There is an axis of increased growth extending from the head towards the feet. The head is in advance of the trunk, and the trunk is in advance of the limbs at all times regarding growth and maturity. And this axis of increased growth gradient, increased growth gradient extending from the head towards the feet, that is called the cephalocaudal gradient of growth. More growth occurs in the lower extremity than in the upper, and even within the upper extremity, within the head also, more growth occurs in the lower jaw than in the upper, because it is nearer to the brain. So what is the result? Acceleration in mandibular growth relative to the growth of maxilla will result, and differential jaw growth is noted. And with growth, the face becomes less convex as the mandible grows, and within the body also there is cephalocaudal gradient. Within the head, within the face also there is cephalocaudal gradient. So mandible being farther away, it grows more and it matures later than the maxilla. Similarly, Scammonn's growth curve, it indicates that different tissue systems have a different timing for growth. For example, lymphoid tissue at the age of 7 to 8 years, it reaches a maximum of around 200% of the adult size, and it gradually declines. Neural tissues at the age of 5-6 years, it reaches up to 90-95% of the development, and it matures earlier. Whereas the general growth, general body tissues follows the sigmoid shape. After the infantile growth spot, it is relatively flat for some time, and again during the prepubertal growth spot, it inclines sharply. In the genital reproductive system, up to 10 to 12 years, that organs are not well developed, and in the pubertal growth spot, the growth is marked. And the growth curve of maxilla and mandible lies somewhere around near neural and general, and since maxilla is near the brain, its curve lies towards the neural growth curve, whereas mandible, it lies towards the general growth curve. The sudden accelerated growth, such a rapid increase in growth rate, it is termed as growth spot. At some age, there are sudden accelerated growth is noted, and basically there are three growth spots: infantile mixed dentition growth spot and adolescent growth spot. In both sex, up to 3 years, infantile growth spot is noted. In mixed dentition analysis, for females it occurs 1 to 2 years earlier, in 6 to 7 years in females and 7 to 9 years in male, whereas adolescent growth spot 10 to 12 years in female, 12 to 14 years in male, and it lasts for 2 to 2.5 years in both the sexes. One who is fully grown, a person who ceases to grow. Further growth is not possible, that is adult. The exact time when a person reaches adulthood cannot be predicted. Biologically, it is accepted that male above 18 years and female above 16 years can be considered adults. Orthodontically, adult patients can be 18 to 25 years, post-adolescent patients, group 2 patients 26 to 35 years patient, and above 35 years group 3 patient. And another classification is under 35 and over 35, younger adults and older adults. And young adult patients are those from professional point of view, they should have received the treatment all year, or those in whom the treatment can be carried out only after the growth completion. Those needing surgical treatment either for class 2 or for class 3 malocclusion, skeletal class 2, class 3 malocclusion. These are young adult patients. And adult patient can be young adult or old adult. Young adult also can be those who could have been treated earlier and those needing surgery. And in old adult, those who have primary malocclusion and those who have developed a secondary malocclusion. This is another classification. Older adult patients over age 40, they present with signs of aging and deterioration or a dentition often characterized by extensive rehabilitation. And these patients present with a secondary malocclusion, that is malocclusion that has developed or has worsened in the adulthood. Previously, a person may have midline diastema that is increasing over the years as a result of periodontal diseases. That is secondary malocclusion. And the reason for the increase in number of adult patients these days is because of increased public awareness, aesthetic conscious society, and people are well accepting that adults can also wear braces. And appliance design has also so improved that many invisible lingual orthodontics is there, clear aligner therapy is there because of all these techniques, and ceramic brackets are there, ceramic arch wires are there. So adult patients are also choosing orthodontic treatment these days, and because of increased affluence, people can actually afford the orthodontic treatment. Because of this reason also, in the adolescent, they don't have enough money to receive the treatment, so as an adult they choose for getting the treatment. Advances in the field of surgical orthodontics, once those patients who could not be treated by orthodontic means, these also can be treated by pre-surgical orthodontics first and then surgery later. Because of that also the number of adult patients is increasing. And general dentist awareness, more and more general dentists are in the rural areas also these days, so they refer the patients with high orthodontic treatment need, and the patient goes to the orthodontist and get the required treatment. Because of all these reasons, the number of adult patients has increased over the years. And for determining the age of the patient, the chronological age means the number of years from the age from the date of birth, that is misleading. So that cannot reflect the exact growth status, because some persons are fast maturing, some are late maturing, and for some growth spurt may occur early and the growth spurt may occur later in some cases. So to check the reliable age for the treatment, skeletal and dental age should be ascertained. Skeletal age or bone age is determined by studying either endostereograph or cervical vertebrae maturation assessment. According to cervical vertebrae maturation statement, up to cervical vertebrae stage 1 to CS6 it is there, and peak mandibular growth occurs between the stages cervical stage 3 and 4, and for that C2, C3 and C4 vertebra lower border is seen, shape is seen, and the height is seen. Either it is trapezoidal, rectangular horizontal, square shape, or vertical horizontal. So by observing the lower border of the C2, C3 and C4 and their shape, we can estimate the cervical vertebrae maturation stage, and we can know whether peak mandibular growth has already occurred or it will occur after 2 years or already 2 years have been passed. That can be estimated based on the cervical vertebrae maturation stage. And one benefit is that no additional radiograph is required, because in lateral cephalogram this estimation can be done. So which patient is still growing based on these two lateral cephalograms? Can you estimate the growth status looking at the cervical vertebrae maturation stage? If you haven't guessed it already, this patient, we can see the border of C2 and C3 are just concavity has started developing. So this is and body is also trapezoidal of C2 and C3. So this patient is still growing, and mandible is lagging behind the growth. So myofunctional appliance can be used in this patient. However, this patient C2, C3 and C4 concavities are prominent, and body shape of the C3 and C4 are vertical rectangular. So the patient is already in CVM stage 6, CS6. Growth has already completed. It is skeletal class 3, and camouflage treatment is very less likely to be successful. So surgical treatment is required for this patient. This is the clinical implication of estimating the growth and age. And diagnosis differs according to age. Normalcy in the one age cannot be normal for another age group. Some of the transient malocclusions, transient means short lasting, which do not need any treatment, they correct on themselves. These are open bite seen in the gum pads. When the patient is when the neonates are edentulous, the gum pads are in open bite state. So after the eruption of the deciduous dentition, the open bite state is corrected. Similarly, spacing in the deciduous dentition, it should be naturally present. If not present spacing in the deciduous dentition, the permanent teeth will be likely crowded. So after eruption of the permanent teeth, this will also be corrected. First deep bite at the age of 3-4 years, when the mandibular growth has not catch up with the maxillary growth yet, first deep bite occurs after the eruption of the deciduous incisors and deciduous molars only, before the growth of the mandible is evident. And floss terminal plane during the deciduous dentition stage, the distal end of the maxillary teeth and the distal end of the mandibular teeth, that is second molar, deciduous second molar, if they are in the straight line, it is termed as floss terminal plane. So that is not abnormal, later, when the mandibular growth catch up, that will eventually turn into Engel's class 1 molar relation. So that is also transient malocclusion. Ugly duckling stage, we'll see later how does it look. Until the eruption of the permanent canines, there will be midline diastema present between the central incisors and as well as some lateral incisors, and flaring of the incisors distally will be present. So that is corrected after the eruption of the permanent maxillary canines. And second dip bite. Second dip bite is present when permanent incisors have erupted. Permanent first molar has erupted, but permanent second molar has not erupted yet. So the bite opening is not yet evident. So second dip bite is present. After the eruption of the permanent second molars after the age of 12, this second dip bite will also be corrected. So these are some of the transient malocclusions present in the humans. This is a case of, guess what is this? Second dip bite stage is present here. After the eruption of the second molar, the dip bite will be corrected. What could be the patient's concern? Is it transient? The midline diastema is present, and is the patient growing? 1, 2, 3, 4, 5, 6, 7, 8. Up to third molar, all the teeth are present. The patient is likely to be adult. This space will not close automatically. It is not a transient condition. Definitive, either restorative or veneer treatment or orthodontic treatment should be done. Aesthetic restoration, if we do, the crown size will be larger, so orthodontic closure of this diastema is required. Similarly, is this transient malocclusion? Is this a transient malocclusion or not? The patient's age is seems to be a child. Second lateral incisors have erupted, whereas the maxillary canines have not erupted yet. So this is the ugly duckling stage. What I have mentioned earlier, it is a transient malocclusion. This is the radiograph OPG of the same patient. Permanent canines are yet to erupt, so the maxillary central and lateral incisors are flaring. After the permanent canines erupt, then the ugly duckling stage will be corrected itself. This is the picture depicting the flush terminal plane. If the growth is normal, class 1 molar relation will result later. If the mandibular growth is retarded, then only end-to-end relation, end and molar relation will result. So what are the possibilities when distal step and mesial step are present in the deciduous dentition? That is also given here. Considering the fact that orthodontic and dentofacial orthopedic treatment is most effective during the growth, the assessment of skeletal maturation is very important for the success of the therapy. And what are the benefits of early treatment? There is scope for some good growth modification. In adult patient, what happens is that the changes can be brought about by only the movement of teeth, only the movement of dentition, and either surgical or by tooth movement. But in the case of growing patients, there is scope for growth modification and harnessing natural growth forces. Teeth tend to migrate mesially. So if the first molar is extracted during the growth stage, second molar will migrate into the first molar space. So that is the benefit of early treatment. And scope for prevention and interception. If the space is decreasing, we can use space regainers, and space maintainers also we can use for prevention of more severe malocclusion. Distalization of the molars can be done. And minimizing the psychological distress. When the patient of 11-12 years old has to wait till 18 years old for getting the proper orthodontic treatment, if early treatment is provided, then the psychological distress that has to be borne by the patient is reduced. So that is some benefits of early treatment. And what are the benefits of late treatment? What are the characteristic features in the late treatment is that growth is already completed, so we cannot harness the power of growth. Growth modification cannot be done, only the surgical or orthodontic tooth movement is done. Limited treatment options are present. And in adult patients, due to different systemic conditions, periodontal conditions, function, aesthetics, and treatment stability, one may need to be compromised. So all the objectives of orthodontic treatment of Jackson's triad, this functional efficiency, structural balance, and aesthetic harmony, that may be compromised in the case of adult treatment. And with age, various considerations has to be done while performing the tooth movement. Vitality of tissue, since the young patients have increased vascularity and cellularity of the periodontal membrane, they are more responsive to orthodontic forces, which makes it possible to move the teeth faster. And because of growth also, younger growing patients react more favorably to orthopedic forces and orthodontic forces. And apical foramen are closed in adult, due to which force application may increase the chance of non-vitality, root resorption, and ankylosis of tooth. Because in young patients the apical foramen is wider, there is less chance of pulpal damage. Similarly, density of the bone, from the age 25 to 75 years, there is about 1% of bone loss every year. So in adults, tooth movement will be faster where the bone thickness is less. But compared to adolescents, young adult around 25 years old, compared to adolescent, their bone is thicker and tooth movement is reduced compared to adolescents. Similarly, for appliance selection, extraoral appliances, these are not well accepted by adult patients, whereas child do not have any problem wearing them, and adult patients are more selective about the appliances. They need as small sized appliances possible, clear aligners if possible, lingual orthodontics if possible. They want to have the treatment but without the noticing by others. So it is difficult to get adult patients to have orthodontic treatment. And periodontal health, periodontal recession and many restorations has to be done, and multidisciplinary treatment approach has to be applied in case of adult patients, whereas the periodontium is healthy and only the orthodontist can perform the required treatment in young patients. So based on the different factors like growth potential, general health, dental status, and periodontal health, motivation and cooperation, in child motivation and cooperation can range from poor to excellent, whereas adult patients are highly motivated and cooperative. They will maintain good hygiene. And appliance design and aesthetics will not be a concern for a child, but that is a major concern for adult patient. General health, in the adult patient, they have many systemic conditions. They may be taking multiple medications, compromised dentition and edentulous space caries, failing old restorations are present in adult patient. That all has to be considered while making the treatment plan. Similarly, appliance tolerance is high for the child patient, whereas it is very less for the adult patient. Children learn to adjust quickly with the appliance, and encouraged planning is less challenging for the young patients, whereas encouraged planning is more challenging in the adult patient. And only a short term retention of 6 months is sufficient for young, whereas long term permanent retention may be required in case of adult patients. Appreciation of treatment outcome, adult patients will appreciate the treatment outcome. They will thank you for the result you have brought in them, whereas child patients, they cannot appreciate what changes they have got. So motivating them to keep the oral hygiene and maintaining of the compliance from the child or adolescent patient, it is quite difficult. These are some basic differences between child and adult patients. These are the reference for today's presentation. If you have got any queries, please ask in the comment section. I'll try my best with answer with references. Thanks for watching. Stay subscribed. Thank you. See you in the next video.